So let's say you're someone that has EDS, walking around, living your life, and then you get sick and you develop POTS. What do you do about that? My name is Dr. Nathan Keiser, and I want to share with you guys today a case of someone who walked just through that and how we were able to take that history that had been long, protracted, multiple years, and within about a month, get that person up and running again. So it's a compelling case. I hope it's useful for you. At least you'll be able to learn something from it. But I think it's good to start with the background of what is Ehlers-Danlos syndrome. That's a good place to start. So it's a genetic condition. And in the type we're looking at here, it's specific to the hypermobile type, which means people tend to be hyperflexible. Their joints have more range of motion than typical. We can measure that using simple Beighton scores. You can also do genetic testing to understand if this is you, but typically the way this looks is someone is very, very flexible. Lots of range of motion in their joints. Their knees kind of buckle backwards, their elbows buckle backwards. They can move their wrists more than they should. Joints everywhere. So, and then we think about also usually a hypermobility in the skin or increased elasticity. And then there are these kind of gray spaces where people with EDS are more prone to different things. One of them being more chronic pain, more fatigue. And we're kind of trying to understand what that means for people when they suffer with things like POTS. POTS is postural orthostatic tachycardia syndrome. It's a common diagnosis that a lot of these folks get. And it's where when you move from a laying down to a standing position, you see a large acceleration in your heart rate, usually 30 beats or more. And it's protracted, meaning this is happening for a long time, 6 months or more. It's not something that like one day you wake up, you feel a little funny, you're dizzy when you sit up, 30 beats per minute, and all of a sudden I have POTS. It's something that happens day in, day out for a long period of time. So she's actually diagnosed with this, but we're going to come to that a little bit later about what is actually going on there, which, by the way, to spoil it, is super important for her case, is actually understanding what's going on here. So this was kind of what she was dealing with 2 years ago. Well, let me back up. So over the course of about 8 years, she'd been experiencing some symptoms particularly related to her GI system. A lot of trouble with digestion, bloating, not feeling well, had some lymphatic problems in that area as well, like just a tough way to spend time. 2 years ago, this progressed into a more severe version. We're getting sick now. And then just over the last few months later after that, she started to have problems with being able to stand up, feeling like she's going to pass out, and then at one point fainting, which is important. We want to make sure that that's not something that is a short-term thing, that's like a general symptom trend when we look at these types of cases, which is what she experienced. So when she came in, the primary complaints she had were she'd been diagnosed with POTS. She was having a lot of nausea and stomach pain. She had this previous diagnosis of Ehlers-Danlos syndrome and extreme fatigue to the point where it was affecting her ability to go to school, affecting her ability to work, and to kind of pursue the things that she was looking to do in school. So a very, very, very big deal for a college-aged young lady. So kind of moving forward with that, there were a lot of things going on in history. She's got a history of some spinal problems where she's developing joint arthropathy at a young age, which is abnormal. We're working with severe night sweats, difficulty sleeping. So kind of a lot of nuance in this case, because there are a lot of different pieces going on. So from there, what we want to think about is, what is this? Obviously she's missing class, obviously she's not able to kind of socialize or have normal interactions in that way, missing out on opportunities relative to school. So what we did was I'll walk you through the approach that we took in understanding what's going on and kind of digging through what these problems are and how do we then work them forward. I think it's really important to start with this Ehlers-Danlos component because it's genetic, right? So you have it, fine. But also I've seen like a load of people, you see videos of people with no arms that are, world-class archers. You see people with no legs that are world-class wrestlers. So in this particular circumstance with Ehlers-Danlos, from my experience, what I have seen, it doesn't have to be something that completely voids your ability to have a healthy, happy, productive life. But it is something that we have to have a lifestyle around so that we can achieve those things. So I think starting from there is important. But then, so we look at some of the diagnostics that we found where we noticed, one moment, pull these up so I don't mess them up here. We noticed a couple things relative to the neurological exam at first. So number one, just shining a light in her eyes caused her to have a titubation of her head, where she has this little tremor in her head. That's not something that you would see just specific to the fact that your joints are bendy and that your heart is beating fast, right? We found that she had percussion myotonia, where we tap her thenar eminence, she would get the same sort of consequence where she could get this myotonia bilaterally. We start looking at changes in respiratory outputs when we see these things, so it's very important. Measuring her peripheral nerves is really important because in these cases we can see changes in neuropathy, both injury to the nerve itself, but also when we have POTS, a lot of the times what we're looking at is, are they able to actually get adequate blood flow to the head? Many times that acceleration of the heart rate is in an effort to compensate to get blood into the head. So that's kind of the next thing. When we do this peripheral nerve exam, we want to differentiate, are the nerves working the same all the time? Are we actually having damage in the nerves themselves, causing kind of numbness and tingling or coldness or difficulty being able to control blood pressure in the periphery? And these times we see like kind of some purple color that starts to come in. We call this acrocyanosis. Sometimes you'll see mottling, which is like a spiderwebby appearance that happens, usually in the legs, but sometimes it can happen in the hands too. All these things point toward peripheral nerves not being able to do their job. But the question is, are those peripheral nerves not able to execute because there's something damaged in the peripheral nerve? Is that damage a temporary damage, just like an inflammatory damage? Or if it's something that is more chronic and long-term, and differentiating the two is really important. So in her case, she had a decrease in her ability to detect temperature, both warm and cold, in the periphery of her hands and in her feet. And these are small nerve fibers that don't have myelin in them. So that's very important. These are just kind of small, bare-ending fibers that aren't conducting as well. We also look at that compared to what we see with pain and temperature. So we use a little pinwheel and we rub that on the skin. And when you roll that along the skin, we should feel these little pinprick sensations. And what she was experiencing when she was sitting up was that they were really patchy. She could feel them in some places, not feel them in others, but it wasn't anything that went along a specific dermatome that would make us think it's coming from the spinal cord. It wasn't hemiplegic, making us thinking that it was coming from the brain. It was this patchy type of a distribution. So then what we do when we see that is we compare that to larger diameter fibers that have a lot of myelin on them. They're a little more coated, they're a little bigger, a little more robust. These ones, these vibration and joint position senses, these were relatively normal. She was able to kind of move and do the things that you would expect to do in a normal case. Then when we have her lay down, and we check the pulses in her head to make sure her intracranial and extracranial pulses are normal. Like, is she getting blood flow to that? And one of the things that we noticed with that was, if I back up a step, because I'm skipped a part, we also check to make sure that the color temperature that people perceive in their vision is the same bilaterally. And we want it to be the same when they're seated as when they're laying down or when they're standing up. It should just never change. The way that you see color shouldn't be posturally dependent. But sometimes it is, because the first blood vessel that comes off the middle cerebral artery is the one that goes to the back of the eye. And that helps us to detect color, visual acuity, these things. So a lot of people that have problems getting blood to their head will notice changes in their vision peripherally, particularly relative to the way they see color, but it can also be with the acuity or blurriness that can come in over an eye as well. So that's really important. Moral of the story for her is that her response was different sitting up than it was laying down, which is super important. So we see that patchiness of the sensory loss attenuate, so it kind of goes away when she lays down. When we position her head in a certain way, we find by extending her head, she gets improvement in the pulses extracranially. And then we see that the color that she had different, that burgundy sort of color, that darkening of the red that she experienced in her vision normalized when she's laying down. So this helps us understand that there's something different about sitting up than there is laying down for her, and it affects the way that she is able to actually use her brain to process these peripheral inputs. So it doesn't mean there's something wrong with her eye. It doesn't mean there's something wrong necessarily with dead nerves in her legs, but the ability to use them and detect them and work with them from a brain perspective is being impaired. So that part's super important. So if we kind of go the opposite direction with that and we say when you're laying down, things get better than they were when you were sitting up. What happens when you stand up? And in this case, we looked at standing just on a foam pad. If you're familiar with this, you may have done this test already, but standing on a foam pad, we just have you stand there and close your eyes. And then we'll have you close your eyes and turn your head in both directions. We'll have you tip your head forward. We'll have you tip your head back. And what we're trying to see is how well your brain is able to incorporate all of these different senses and turn that into balance, which for most people in a healthy environment is not a problem whatsoever. But what we saw in this case was that she actually had falls, which is like a very impaired level of balance when tipping her head forward, when turning her head to the left, and when extending her head. And in all of these, she compensated by turning her body to the right while she was doing all of these tests. And that helps us understand where she feels comfortable, where she feels stable, where she feels safe, but what all of those mean is where she's able to perceive her sensory system best. Okay, so hopefully that's useful to you. Then while standing, we have them take a little walk. And in that walk, we'll watch how do things look like when you're just walking normally. And then, but also how do they look when you're doing something that's hard, when you're thinking. We may have you do a math problem. We may have you do all sorts of things I'm not going to tell you about here so that we can kind of keep them secret. When we do that, we're looking to see, does it change the way you walk? Normally, you should be able to walk and talk at the same time, right? We talk about walking and chewing gum. In this case, when she was walking and thinking, she would freeze. So every step, she would kind of have to stop and halt while she was thinking. She couldn't do them both at the same time. So this is really helpful for us. So just from that physical portion of the exam, we can already see some areas in the brain that aren't shaping up the way they should be for a 20-year-old. The question we have to then think about is this something that is an error within the neurology of the brain itself? Or is that neurology not able to run on all cylinders because it's not getting enough fuel, it's not getting enough oxygen and glucose, which is delivered through the blood? So that's kind of the next question we have to ask. We also looked at some pretty important measures relative to the way that we move our eyes, because we wanted to understand how much of this could be relative to a problem with the vestibular system or with integrators of the vestibular system in the brain. So if we don't understand where we are when we turn our head, when we lay back, when we sit up, when we stand up, we want to know to what degree is the vestibular system involved. And with her case, when we cover her eyes and there's nothing to look at, but she's just looking straight ahead in the dark, she has a drift with her eyes drifting down and then popping up, which is associated with a particular kind of a central vestibular condition. So we see that there's an overlay in this, which is a big deal, because if that system's not working very well, all of the other things that go with understanding where your head is are going to be compromised. Kind of a big deal. So from there, we went on to do a tilt table examination. And in the tilt table examination, for those of you that aren't familiar, we lay down, we look at what are all the vital signs looking like when we're laying down. What's your heart rate? What's your blood pressure? What's your breathing look like? How much blood is traveling through the arteries into your head? Is everything running the way it should be? And then we will actually tilt you up and we will look at the difference between the two. Normally just tilting up to 70 degrees shouldn't be enough to really compromise those systems in a major way. We might see changes in vital systems. We might see compensations that happen for different reasons. Simple things like even just having, being dehydrated or not getting enough sleep. Those kinds of things can affect this as well. What was interesting about this case was at 7 a.m., I think that the test was at 9 a.m. But at 7 a.m., she took a dose of atenolol. And that's kind of important because atenolol should modulate heart rate. So should artificially suppress the heart rate by blocking some receptors at the level of the heart. But what we found was actually that even though she was on that medication, she actually still had these pretty marked changes in her physiology. So she still had a pretty sharp increase in her heart rate, but it wasn't to the point of reaching pathology. Her heart rate came up 23 beats per minute, which is a lot, but not enough to be considered pathological, right? So it's attenuating in that way. Her blood pressure stayed relatively similar at about an average of 118/73, okay? But what was interesting was what we actually saw was the change in the way that her blood was circulating carbon dioxide. Normally this level should be between 35 and 45. Hers actually dropped from a 35 when she's laying down to a 26 to a 23 to a 21 as she was standing up. And at the same time, we could also see that she dropped the blood flow going through the middle cerebral arteries into your brain. In both sides, they both actually dropped by more than 30%, which is a pretty big drop. So what we would call this, we have, when we see the decreased levels of CO2, that's called hypocapnia. So it changes the concentration of CO2 in our blood flow, which changes some reflexes, especially within the brain with the way we deliver blood in the brain, and actually causes vasoconstriction in the brain. Vasoconstriction in the brain leads to a buffering of blood flow, meaning it starts to close off the amount of blood flow into the brain. So we actually see this pretty significant drop. The question would be like, can you feel that? Do you know that that's happening? Like when the blood flow in your brain drops, what's the deal? So she felt it right away. So the way that she marked it, she said she had lightheadedness and dizziness, which turned into nausea, shortness of breath, felt it in her stomach, felt hot, weak in the legs, and then returning back down, she finally felt like she could recover and breathe again, but she was still dizzy as the blood flow started to return to her head. It actually took several minutes before the end-tidal carbon dioxide levels normalized and the cerebral blood flow velocity to her brain normalized. So what this tells us is that yes, she has this history of EDS, right? She's got this history of these GI problems. She's got this kind of new diagnosis of POTS. What is going on that makes her feel like she's absolutely fatigued? She can't be up and around doing things. She gets crazy nausea. Well, that comes down to this capacity, like all of these things are controlled within your brain, right? They're all in the control system, in the computer of your brain. So the simple question would be, is if you are not able to maintain normal reflexes around how much blood is going into your brain, you're going to have impaired functionality on the other side. It's just going to happen that way. And especially when you see reductions that are this severe, they're going to affect other vital capacities. So the job in this case was to think about, well, how do we then attack each of these things to try to get her on the right side of how she's feeling? So you saw we had these vestibular problems, meaning we have to do something that allows her to understand where her head is. If she's got this drift of her eyes or this perception of movement in her head, any movement of her head or a change of position is going to be met with an inaccurate motor response. She's not going to be able to send blood to her in an effective way. So number one, we have to deal with that. We also see this patchiness in the nerves. We're going to use that as a way to see if we can increase the firing rate into the brain. And then we also saw that there was an element of changing the position of her head and neck that changed the blood flow into her head when she was laying down. So we built a series of exercises that could take us from that position of stability when she's laying down, changing the orientation of her head and neck to be able to stimulate the joints in her neck in a different way so that she could maintain the blood flow. And then doing the vestibular rehab to gently move her through space in a way that she could tolerate. And what I mean by that, we basically do that tilt table, but rather than do the test where we go up and down, we do these small exercise versions of it. So like if you imagine if you if you were recovering from being sick and you couldn't go for a walk, but maybe you could start out by just like standing up and just picking your feet up and down like this, right? So maybe you're not able to walk yet, but even just picking your feet up, you start to get out of breath, you work, but eventually you get stronger again. So you take like the thing you want to do and you break it down into smaller chunks and then you rehab it like that. The trick is if you go too hard, sometimes your symptoms feel worse. It's harder to get out of bed. It's harder to keep momentum. But if you can exercise at a rate where the symptoms aren't too bad, you're going to be uncomfortable because you're pushing the system, but it's enough to where you can recover and come back the next day and do it again. So that's the way we approached it. So we measured the CO2 ratio so that when she was going up, we never went past what she could tolerate. And because we did that, never caused the vasoconstriction. It never caused her to lose that blood flow to the brain. So she was able to learn how to do it on an ongoing basis. So step by step, being able to go up higher and higher and higher and to be able to tolerate it so that we could then move into actual physical exercise to be able to continue to take the ability to lay down and have blood flow in your head, turn that into stand up and also still keep blood flow in your head, to then be able to do more high level tasks with blood flow in your head. And through that process, we were able to retest the tilt test to where she could go from 0 to 70 degrees without having a drop in the carbon dioxide, which is super cool. And then at the same time, because of that, she didn't have the drop in the mean arterial blood flow, meaning she's keeping blood in her head, which is amazing. From there, we can then say, okay, well, if that's true and she can stand up and deliver blood to her head, let's look at some of the other things that went with that. So then we're not seeing the change in her vision anymore when she's sitting up. We're not seeing the change in her sensory distribution when she's sitting up. We can see she can stand up, close her eyes, and turn her head in all these positions so she can balance. When we put the cover on her eyes aren't drifting and bouncing anymore, causing that nystagmus. So all of those things going together means that her brain is able to compute at a higher rate and to be able to do it in more difficult contexts. So that is kind of the extent of it as far as what we were able to do in the lab. And then from there, we say, okay, we've got these things set up. Here are some exercises that we're going to do, and let's go ahead and do them at home. And over the course of a couple weeks of doing it at home, we get a report back. Things are going well, starting to look into a new job. And then obviously going back to school, here we are in the fall, that's starting up right now. So all of these things are trending in a good direction. But the point I want to make is that sometimes we see these things like EDS, we see these things like POTS, that if we look around on the internet too long, you can feel very defeatist about what your opportunities are. But if we instead flip it and say, well, how do I take this body that I have? It's the only one I get. How do I be able to take that and train it into something that is more useful, something that we can live a happy and healthy life with? And my assertion in this case was that we were able to find a way to help her do the thing that she was lacking, which is be able to move around in her environment, and while at the same time be able to get a substantial amount of blood to her head to where she can do all the activities that she wanted. So by not having that available, obviously we're going to be fatigued, we're going to have the symptoms that are associated with it, and we're not going to be able to live the life we want. So I hope that's helpful for you. If you have questions or comments, please leave them. Also, I don't get a chance to get to all the comments. So if you'd like to reach out, the way I'm most accessible is actually through email. That should be attached here as well. But I hope this is helpful. And if you know somebody that you think it would help, please share. Thanks.